Welcome to our first video on fat-soluble vitamins. Let's begin. Here are the topics we're going to discuss in this lecture. Let's start with vitamin A. We will cover general characteristics, vitamin A deficiency, vitamin A toxicity, and therapeutic uses of vitamin A. Let's start with general characteristics. Vitamin A is also known as retinol. It can be found in liver fish, spinach, and carrots. And its storage is in ito cells or stellate cells in the liver. This vitamin acts as an antioxidant. It also plays an important role in cell differentiation, particularly the epithelium, and it is involved in nocturnal vision since it is a compound of visual pigment found in retinal rods called rhodopsin. Let's move on to vitamin A deficiency. Various causes contribute to this deficiency. The main one is fat malabsorption, which is seen in conditions like Crohn's disease, cystic fibrosis, or pancreatic insufficiency. And another cause is malnutrition. Some of the common clinical features of vitamin A deficiency are scaly skin, keratomalacia, night blindness, bito spots on the cornea, and immunosuppression. Keratomalacia is characterized by dryness of cornea, which may lead to corneal ulcers and bacterial infections. Vitamin A deficiency may increase the risk of severe measles in the population. Bito spots are gray, triangular patches that form on the bulbar conjunctiva of the eye. They are caused by metaplasia of squamous cells of the conjunctiva. Let's move forward with the workup and treatment. The diagnosis is mainly clinical, but in some cases, measuring serum retinol levels may help. As for the treatment, vitamin A replacement should be performed. A 5-year-old boy is brought to the physician by his mother due to dry skin. She noticed diffuse scales when she was bathing him. His mother has also noticed her son has difficulty walking at night because, according to him, he cannot see anything. The physical exam reveals a malnourished boy with white, foamy structures on his conjunctiva. Deficiency of which nutrient is most likely causing this patient's symptoms. This malnourished boy presents with dry skin and diffuse scales. He also has difficulty walking at night because, according to him, he cannot see anything. Visual impairment at night is known as night blindness or nyctalopia. The physical exam reveals white, foamy structures on his conjunctiva. These are consistent with bito spots. Dry, scaly skin, nyctalopia, and bito spots are most likely due to deficiency of vitamin A. Let's continue with vitamin A toxicity. The most important cause for this condition is oversupplementation. The clinical features of vitamin A toxicity can be divided into 3 categories: acute, chronic, and teratogenic. Acute toxicity presents with nausea, vomiting, blurred vision, headache, and vertigo. In chronic toxicity, patients present with dry skin, alopecia, hepatic toxicity evidenced by elevated ALT and AST, as well as arthalgias and idiopathic intracranial hypertension. Let's step back and remember the idiopathic intracranial hypertension. It usually presents with headache, vision changes, papilledema, and abducens nerve palsy. The diagnostic workup includes MRI to rule out an obstruction or mass, then performing lumbar puncture, where an opening pressure of more than 250 millimeters of H2O without any other findings is diagnostic. In the last category in our slide, vitamin A toxicity is a known teratogen. It causes cleft palate, microcephaly, thymic agenesis, and cardiovascular abnormalities. Therefore, when a woman is going to be treated with isotretinoin for acne, pregnancy must be ruled out first. Then, 2 forms of contraception should be applied before the start of treatment. Let's continue the diagnostic workup and treatment of vitamin A toxicity. The diagnosis is mainly clinical, taking into consideration the history of use of vitamin A supplements by the patient. Treatment requires stopping vitamin A supplementation as well as restriction of foods that are rich with vitamin A. Let's move forward with the therapeutic uses of vitamin A. Vitamin A has been used therapeutically in various conditions. It is used in the treatment of measles, especially for children in countries with resource-limited settings, as it reduces the risk of complications and mortality. In dermatology, vitamin A has multiple uses, such as reducing wrinkles and treating severe cystic acne. Vitamin A is even used as all-trans retinoic acid to treat acute promyelocytic leukemia, a subtype of acute myeloid leukemia. Let's try a question. A 7-year-old girl is brought to the physician by her parents due to diffuse rash that started 3 days ago. She started coughing, and she had runny nose and red eyes 1 week ago. She also noticed red spots with white center on the inner side of her cheeks. The patient is not vaccinated due to parental preferences. The physical exam reveals a malnourished girl with diffuse maculopapular rash. Which nutrient should be supplemented in this patient's diet to improve the overall prognosis of her current condition? This patient presents with diffuse maculopapular rash, preceded by cough, coryza, and conjunctivitis. She also noticed red spots with white center on the inner side of her cheeks. This description is consistent with Koplik spots. Considering that she is not vaccinated, she most likely has measles. Malnourished children with measles should be supplemented with vitamin A because it improves the overall prognosis of the patient. Let's move forward with our next section, vitamin D. We will cover general characteristics, vitamin D deficiency, vitamin D toxicity, and therapeutic uses of vitamin D. Let's start with general characteristics. The active form of vitamin D in the human body is calcitriol, or 1,25-dihydroxycholecalciferol. Vitamin D can be found in plants or fungi as ergocalciferol or vitamin D2. It can also be found in fish and milk or synthesized in the skin with the help of sun exposure as cholecalciferol or vitamin D3. Lastly, vitamin D3 is stored in adipose tissue as 25-hydroxycholecalciferol. Before I go any further, I'd like to mention this image was contributed by Amboss. So thanks to our partnership with Amboss, I can highlight several important features of vitamin D synthesis. First, in the liver, 7-dehydrocholesterol or provitamin D3 is synthesized from cholesterol. Subsequently, in the skin, thanks to ultraviolet radiation, provitamin D3 is converted into vitamin D3 or cholecalciferol. Cholecalciferol requires the activity of the enzyme 25-hydroxylase to be transformed into 25-hydroxycholecalciferol or calcidiol. 25-hydroxylase is produced in the liver. Finally, in the proximal convoluted tubules of the kidney, the enzyme 1-alpha-hydroxylase is responsible for producing 1,25-dihydroxy vitamin D3 or calcitriol. It's important to note that parathyroid hormone and CAMP stimulate this reaction, while calcium phosphate and fibroblast growth factor 23 inhibit it. Let's continue with the functions of vitamin D. First, it increases calcium and phosphate absorption in the gut. In addition, it promotes reabsorption of calcium and phosphate in the kidneys. And finally, it stimulates bone mineralization. Here is another Amboss image. We will highlight some important points in the regulation of calcium and phosphate. When serum calcium decreases, parathyroid hormone, PTH, tries to increase calcium levels through several mechanisms. First, it increases bone resorption, which releases calcium and phosphate in the blood. In the kidney, it increases calcium reabsorption and decreases phosphate reabsorption. Moreover, it stimulates the expression of 1-alpha-hydroxylase in the kidney, the enzyme that activates vitamin D. Once vitamin D is activated into calcitriol, it enhances mineralization in the bone. The absorption of calcium and phosphate in the gut and the reabsorption of these in the kidney also increases, which in turn elevate their levels in the blood. Let's move on to discuss vitamin D deficiency. There are several causes that could lead to vitamin D deficiency. These include malnutrition and malabsorption, for example, in the setting of cystic fibrosis, pancreatitis, or celiac disease. Reduced sun exposure and chronic liver and kidney disease are involved as well. Remember the roles of sun exposure, liver, and kidney in vitamin D synthesis we talked about. Finally, infants who are breastfed but have not received vitamin D supplementation may also develop the deficiency because vitamin D is not found in breast milk. Vitamin D deficiency causes different syndromes depending on the age group. In adults, it causes osteomalacia due to alteration in bone mineralization. This can manifest as bone pain, pathological fractures, or myopathy. Osteomalacia will be covered in greater depth in another lecture. In the pediatric population, vitamin D deficiency leads to rickets that we will discuss in the next slides. So, rickets results from impaired mineralization that leads to accumulation of osteoid in the bone. Its clinical presentation is characterized by bone deformities. For example, frontal bossing, bowing of the legs, also known as genu varum, and kyphosis. Additionally, patients typically have hypocalcemia due to poor calcium absorption in the gut. Manifestations of hypocalcemia include tetany, positive Shostak and trisocine, and QT prolongation on ECG. This image shows the frontal bossing or protruding forehead that may be seen in children with vitamin D deficiency. It results from thickening of skull. Let's look at this image on the left side where we can see Shostak sign. Please note the small contractions in the facial muscles when tapping on the facial nerve in front of the ear. On the image on the right side, we can observe Trousseau-sign. It is the carpopedal spasm that occurs minutes after the insufflation of the cuff to measure the blood pressure. Again, these two signs can be seen in the setting of hypocalcemia. Let's continue with the diagnosis and treatment of vitamin D deficiency. Laboratory testing can show low serum levels of 25-hydroxyvitamin D or calcidiol. Serum levels of calcium and phosphate are low because they are poorly absorbed in the intestine. As a consequence, serum parathyroid hormone and alkaline phosphatase can be increased. Imaging, specifically X-ray, may show some characteristics of vitamin D deficiency. For example, widening of growth plates, metaphyseal cupping, and rachitic rosary. As in most vitamin deficiencies, the treatment is vitamin D replacement. This image shows a chest x-ray of a patient with rickets. Please note the prominent nodules known as rachitic rosary. These result from enlargement of the costochondral junctions. This x-ray shows another bone deformity of rickets, that is the bowing of legs, also known as genu varum. Also, please note the widening of the growth plates and metaphyseal cupping, which results from accumulation of non-mineralized osteoid due to vitamin D deficiency. Let's move on to vitamin D toxicity. There are two major causes. First, granulomatous disorders such as sarcoidosis, and second, oversupplementation. Let's briefly review how sarcoidosis can cause vitamin D excess. Epithelioid macrophages that are found in the granulomas produce 1-alpha hydroxylase. As we mentioned before, this enzyme is normally produced in the proximal convoluted tubule and is responsible for activation of vitamin D. Active vitamin D, in turn, allows greater absorption of calcium and phosphate in the intestine and increased reabsorption of calcium in the kidneys. The clinical presentation of vitamin D toxicity is mainly associated with the resulting hypercalcemia. Common manifestations are bone pain, muscle weakness, constipation, kidney stones, polyuria, depression, and shortened QT interval on ECG. The diagnosis of vitamin D toxicity is achieved by measuring serum levels of calcidiol and calcitriol. Increased serum 25-hydroxy vitamin D can be associated with excessive ingestion of calcidiol, while increased 1,25-dihydroxy vitamin D can be associated with excessive ingestion of calcitriol or granulomatous diseases like sarcoidosis. Also, increased levels of calcium and phosphate can be detected. Regarding treatment, we need to stop the vitamin D supplementation. Also, corticosteroids should be administered if the cause is sarcoidosis. We will finish this section with the therapeutic uses of vitamin D. Vitamin D reduces the risk of fractures because it contributes to reducing falls by improving muscle function and bone density in the elderly. Also, some studies suggest that it could have some effects on immune system enhancement. The mechanism by which vitamin D enhances the immune system remains unclear, but it is thought to be mediated by vitamin D receptors present in most of the immune cells. Let's end our lecture with a question. A 25-year-old man comes to the physician due to increased frequency of bowel movements for the last 9 months. He underwent removal of his terminal ileum due to ileal obstruction from Crohn's disease. His stools float and are difficult to flush. The patient also has diffuse bone pain. His vital signs include a temperature of 37 degrees Celsius, blood pressure of 110/70, heart rate of 90, and respiratory rate of 14. Laboratory findings are significant for serum calcium of 7.4, serum phosphate of 2, serum alkaline phosphatase of 200, and serum parathyroid hormone of 200. Which of the following best explains this patient's laboratory findings? A. Vitamin D deficiency. B. Vitamin E deficiency. C. Vitamin A deficiency. Or D. Vitamin K deficiency. This patient with Crohn's disease underwent removal of his terminal ileum, after which he started having increased frequency of bowel movements. His stools float and are difficult to flush, suggesting steatorrhea. Steatorrhea predisposes patients to fat-soluble vitamin deficiencies. This patient has low serum calcium, low serum phosphate, high serum alkaline phosphatase, and high serum parathyroid hormone, accompanied by diffuse bone pain. All these findings are consistent with osteomalacia due to vitamin D deficiency. Deficiency of vitamin D impairs calcium and phosphate absorption from the gut, resulting in hypocalcemia and hypophosphatemia. Hypocalcemia leads to increased parathyroid hormone production, so parathyroid hormone levels are usually high. Finally, parathyroid hormone-induced activation of osteoblasts results in high alkaline phosphatase. Therefore, the correct answer is option A. This slide reminds us of the diagnostic findings and the treatment for vitamin D deficiency. Let's discuss why other options are incorrect. Option B is incorrect because vitamin E deficiency is characterized by hemolytic anemia with acanthocytes, ataxia, and impaired vibration sense. Option C is incorrect because vitamin A deficiency is characterized by dry skin, immunosuppression, phyto spots, and night blindness, rather than bone pain. Finally, option D is incorrect because vitamin K deficiency is associated with increased bleeding tendency rather than bone pain. And that concludes this section.